brain tumours, they've kind of got an aura about them of fear and complexity. I mean, it takes a brain surgeon to treat brain tumours. Let's have a think about the key concepts in brain tumours. So the grade of a central nervous system tumour determines its outcome more than anything else. This is unlike many tumours in the body, where the stage determines the outcome. Brain tumours sound complicated, but actually they're all named after their cell of origin. The problem with brain tumours is they grow in a small space and compress areas of vital brain function. This process is what makes brain tumours so dangerous, even if they're benign. The most common brain tumour is the astrocytoma, of course arising from astrocytes. It forms 80% of adult primary brain tumours, and these brain tumours occur at a younger age than most tumours, occurring between the age of 30 and 60 years. Patients typically present with focal neurologic deficits relating to the position of the astrocytoma. For example, headaches because of the increased pressure, seizures, or cerebral edema and mass effects. Astrocytomas have 4 grades, low grade through to high grade, and the high grade lesions have leaky vessels that exhibit contrast enhancement on imaging. You can see here the highest grade of brain tumour, the glioblastoma multiforme, in a contrast CT. Note that it has ring enhancement. This is because the leaky vessels are forming edema around the edge of the tumour. That dark bit in the middle is the tumour. Glioblastoma is the highest grade and the most common of the brain tumours. It arises from astrocytes. The name glioblastoma multiforme derived from its macroscopic appearance, which had multiple areas of white and softer yellow, focus of necrosis and cystic change and hemorrhage, which all gave rise to a very variegated appearance. We call these tumours glioblastoma now. The prognosis for glioblastoma is poor. Despite resection and chemotherapy, the mean survival is only 15 months and only 25% of people are alive at 2 years. In the picture to the right, you can see a glioblastoma arising in the cerebral hemisphere of the brain. Notice its variegated surface, but also notice the way it's pushing over the midline. This tumour is causing an expansile effect in that hemisphere. Meningiomas are a very common but benign tumour of adults. They arise from meningeal cells, specifically from the arachnoid meningothelial cells that are attached to the dura. The tumours are usually rounded masses with well-defined dural bases that grow into and compress the underlying brain. They easily separate from it. They can shell out. And for that reason, once a meningioma is removed, the patient is usually cured. Macroscopically, they're firm and white. There's no necrosis or hemorrhage here. They have cymoma bodies in them. Cymoma bodies are little foci of calcification. When meningiomas are cut, they can be quite gritty due to the calcified cymoma bodies. Schwannomas are another benign brain tumour. Now, you probably think of Schwann cells as being part of the peripheral nervous system, but remember all those cranial nerves that exit from the brain. They're covered in Schwann cells. Schwann cells are normally associated with the vestibular branch of the 8th nerve at the cerebellopontine angle. You can see a tumour here at the CP angle in the picture. It's the white rounded area on the right side of the patient, just adjacent to the cerebellum. There's another name for these vestibular schwannomas, one that you might know, an acoustic neuroma. It's not actually a neuroma, it's a schwannoma. Neuromas are formed of nerve cells, but the vestibular schwannoma, or what we don't call acoustic neuroma, is made of Schwann cells. Patients present with unilateral tinnitus and hearing loss. Thinking about tumours that occur at the cerebellopontine angle gives us an impression of the wide range of tumours that can occur within the skull. Tumours that occur at the cerebellopontine angle include the vestibular schwannoma, that we're not going to call acoustic neuroma, epidermoid cysts, meningiomas, and really primitive tumours like medulloblastoma. Also here is a complicated set of nerves that can be affected: the trigeminal, the facial, and the auditory nerve. On my right here are photos of a patient who has a CP angle tumour. He has facial weakness because the tumour is affecting the facial muscles and the trigeminal muscles, and he probably also has hearing loss. You can see here a tumour indicated by the blue arrow at the CP angle. The most common tumour in the brain overall isn't a primary brain tumour, but a metastasis. The brain receives a large amount of blood, and so that blood carries with it scatterings of tumour cells from elsewhere. The tumour cells settle on the edge of the vessels and then break through and grow in the brain. There are some kinds of tumours that are particularly receptive to growing in the brain. Epithelial tumours like lung cancer, breast cancer, GI cancer, all metastasize to the brain. The picture here shows a melanoma metastatic to the brain. Multiple cannonballs of dark tumour cells. Melanoma has a particular predilection for metastasizing to the brain. Metastases also have leaky vessels in them, and so have ring enhancement. So how do we tell the difference between a primary brain tumour and a metastasis? The answer is going back to first principles. Metastases are not usually single. You can see here in this MRI that there are in fact two lesions. A larger ring enhancing lesion towards the frontal lobe, and then a bit further posteriorly a second ring enhancing lesion. Multiple lesions in the brain are usually metastases. Both primary and secondary brain tumours can cause brain swelling, sometimes from leaky vessels and sometimes just because the tumour is a space-occupying lesion. Swelling of the brain can also occur because of injury to the brain. The diagram on the right shows what happens when the brain swells. It's swelling inside an enclosed space. So when it swells, vital structures get compressed, mainly by herniation. So herniation is when bits of brain kind of squash under structures. For example, in transtentorial herniation, the uncus gets pushed through into the posterior fossa. Other common sites of herniation are between the two cerebral hemispheres under the falx cerebri and down at the base of the skull. Back to the key concepts. The grade of a CNS tumour determines its outcome. The worst of these tumours is glioblastoma, a grade 4 tumour that behaves really badly. Tumours are named after their cell of origin. So, the astrocytomas come from astrocytes, the meningiomas come from meningeal cells. Expansion of the brain in a small space causes herniation and compression of vital brain structures. For example, the structures that control breathing. Brain tumours. There's a subset that's a really bad lot. Glioblastoma, multiple metastases. There are also benign brain tumours. These cause dysfunction of the brain by causing it to expand within a small space.